to introduce Dr. Sona Patel. Dr. Patel is a hematologist-oncologist. She did her medicine residency at Loyola in Chicago and stayed there to do her hematology-oncology fellowship, and she has been a member of the medical staff at MGMC and McFarland Clinic for approximately the last 18 months. Bliss Cancer Center is accredited by the National Accreditation Program for Breast Centers, and that into a great degree is due to the efforts of Dr. Patel and her colleagues in hematology oncology department. And she has very graciously accepted our invitation today to provide us with an update in systemic therapies for breast cancer. And please join me in welcoming Dr. Patel.
Thank you, everybody. Thanks for being here today. So let's get started talking about updates in breast cancer. So we're first going to just sort of lay a foundation work and review the treatment algorithm for localized breast cancer, so we have a starting point for all the different new drugs we're going to talk about. And then we're going to spend the rest of the time really reviewing the new advances in breast cancer for both localized and for metastatic disease as well. All presentations often start with statistics. So breast cancer actually, as of 2022, represented 15% of all new breast cancer cases. And this actually was the highest of all cancers. So it beat out colon cancer, prostate cancer, and lung cancer as well. It represents about 7% of all cancer deaths, which is actually a little bit lower disproportionately, and that just tends to be because we have good screening modalities and these tend to get caught early, and we also have good treatment options for our patients, and so the 5-year survival rate tends to be around 90.6%. If you look to the right over here, you can see the pie chart showing that about 95% of cases are found local or regional, so meaning in the breast or in the axilla only, and the minority of cases, so 6% plus or minus 2%, are found at a metastatic stage. So again, this is really in part due to just good screening and surveillance exams that we have available for breast cancer. This chart over here shows the rate of new cases with this line, and then it also shows the death rate over here. So we're about steady in terms of new cases, maybe an uptick recently. But what is encouraging is that there's a slow and steady decline in our death rate for breast cancer. And hopefully this is continuing, and it is in part due to the enormous amount of new data and research that comes out for breast cancer all the time. So what are some factors that relate to the development of breast cancer? So the first one is age. As you get older, your risk of breast cancer increases. Postmenopausal obesity specifically is a risk factor for breast cancer. Interestingly, premenopausal obesity was found to be more of a protective factor than anything. Increased breast density also has a risk factor for developing breast cancer. Higher endogenous estrogen levels, so this is due to medical conditions that might create that, or even taking hormone replacement therapy. Nulliparity or higher age of first birth is also another risk factor for breast cancer. Family history, so whether that means that there is a genetic component to this or you just have an extensive family history with no identifiable genetics, this seems to be a risk factor for breast cancer. And then lastly, alcohol, smoking, and then radiation exposure are also risk factors. Protective factors, so the main one is really physical activity. Breastfeeding is a protective factor, and again, sort of relating to the postmenopausal obesity, if you have weight loss in a postmenopausal woman, that is thought to be protective against breast cancer as well. So screening and diagnosis of breast cancer, there's not really been a ton of changes in the last couple years, but generally it's recommended by different societies that annual mammography begin at the age of 40. And then this should be accompanied by trying to identify women who are at increased risk for lifetime cancer. And so these are done by various models. The most common one is the Tyrer-Cuzick. We also have the Gale model, and there's a couple other ones. And these are actually all reported automatically with mammogram. So if you scroll to the bottom of your mammogram, these numbers are there for everyone to take a look at. So anyone who has a lifetime risk greater than 20% should be recommended to have enhanced screening. And this is usually with an annual mammogram and an annual MRI. And this also tends to begin at the same age. also can begin 10 years younger than 10 years prior to the youngest family member who develops breast cancer. So if the patient had a mother that developed breast cancer at 45, you'd begin her at 35 instead. And then the way I usually like to order these is I stagger them. So get a mammogram and then 6 months later MRI. And then that way, once a year, they're getting both, but they're also getting imaging every 6 months as well. So another screening and risk factor thing to be aware of is that if we see that the 5-year risk for breast cancer is greater than 1.7%, and this is via the Gale model. So again, this is just reported at the bottom of the mammogram report as well. If that is greater than 1.7%, they qualify for chemoprevention with tamoxifen. The strongest recommendation for that comes if their risk is greater than 3%, but anyone greater than 1.7% does qualify. So they should be referred to oncology at least to consider it and have a discussion regarding this recommendation. And then lastly, the radiologists do a great job with this one, is increased density breasts, C or D density specifically. They should ideally get a mammogram or MRI in addition to the mammogram as well. Just one, because we talked about their increased risk, but also two, because of the limitations that mammograms have in finding small or early lumps in these patients. So once we've got an abnormal mammogram or study, the next steps are that radiology will often recommend additional views, and that is really just to confirm that the abnormality isn't just it isn't just an abnormality related to the way the imaging was taken, and then an ultrasound. And what the ultrasound does is it helps delineate the lesion. So is it well circumscribed? Is it spiculated? Because there are some features that are more concerning for malignancy versus others. As we discussed, so if they have dense breasts, I will always get an MRI if they get diagnosed with breast cancer, or particularly with lobular pathology, because these patients are not as well visualized by mammogram as well. Then this is often followed with biopsy, which is typically an ultrasound-guided biopsy with clip placement, but it can also be done MRI-guided too if, for some reason, their lesion is not visualized on ultrasound. Once they see us or the surgeons, there's an examination of lymph nodes, and we're really looking for anything abnormal that we can feel, or particularly if they're matted or not, because that impacts our staging. And then we do a history and physical with basic labs. So further imaging, like full staging scans, are really based on this assessment, whether or not you think they have signs of metastatic disease. If they don't otherwise have any abnormalities on exam or labs or history, then you probably don't need to do any further imaging for especially early stage breast cancers. And then if you did develop or find a lymph node that was abnormal, then we often will do biopsy and clip of the abnormal lymph nodes, depending on where their treatment plan is going. So just a very basic primer on what you might find with the biopsy. So there's two subtypes. There's ductal, which is the most common, and lobular, which is more difficult to image, we talked about. And so often those patients will get MRIs. For the hormone receptor status and the other things that are reported, we've got ER and PR. That is the most common type of breast cancer and is typically lower grade and found at a lower stage. HER2 positive breast cancer is about 15% of all breast cancers and is a higher grade often when found and tends to be a little bit higher stage. And the same thing for triple negative. It also represents about 15% of breast cancers and is a little bit higher grade when found and sometimes tends to be higher stage as well. So here's just sort of a foundational slide. So once we've gotten through the diagnosis and staging of breast cancer, the next step is consideration of neoadjuvant therapy. We're going to talk about a new study in this realm, so we're going to talk about that in a little bit more detail. But once that decision is made, whether or not they go through, then they will go to surgery. And then adjuvant chemotherapy is considered, followed by consideration of radiation. And then the last part is adjuvant endocrine therapy. So this is sort of the treatment algorithm for those patients who have a localized breast cancer. Just some notes on things that I'm not going to go into too much later on is, one, the surgery options tend to be just lumpectomy versus mastectomy with or without reconstruction. That's a very big generalization there. So it does depend on the type of cancer, the patient's genetics, and all sorts of things, but those are the general choices that patients will have. Adjuvant chemotherapy is most often, I would say upwards of 90%, the AC-T regimen, unless they're HER2 positive or there are other circumstances there, but that is generally what we are using for patients. Dr. Hardy did a great job a couple weeks ago doing a talk about radiation for breast cancer. Just the really quick of it and the really big generalization is that if there's a lumpectomy, they're going to need radiation. And then if they do have a mastectomy, if there's any more invasive disease such as node or positive margins, then they will also likely require at least consideration of radiation. The last part of treating localized breast cancer is to discuss adjuvant endocrine therapy, and that choice is generally, again, tamoxifen or aromatase inhibitor. Rule of thumb is that tamoxifen is for premenopausal women, the aromatase inhibitors are postmenopausal, but we can use tamoxifen in a postmenopausal situation dependent on the patient's comorbidities and interactions with other medications and such. So the first area we're going to look at the new research for is neoadjuvant therapy. So these are the patients who are going to be getting treatment up front. The first thing to talk about is, well, who are these patients and why would we do this? So patients who present with an inoperable breast cancer. So this means disease with bulky or matted lymph nodes. So if you can feel them and they're kind of pushed down on exam, those are patients that can't really get good surgical resection of these areas. So those are the patients that we will often do neoadjuvant treatment for. And 3 nodal disease, and that just really means more extensive nodal disease in different areas, and we don't need to go into the details of that, but people with really extensive lymph node involvement, and then those with chest wall involvement. So really these are the inoperable reasons to pursue neoadjuvant treatment. There are certain patients who should receive neoadjuvant treatment with operable breast cancers, and those typically tend to be the HER2 positive patients and the triple negative patients, particularly if their centimeters are big, or their tumors are greater than 2 centimeters. We can consider it if they're less than 1 centimeter as well, but typically it's recommended if they're at least greater than 2. Patients who desire breast conservation, so with a large tumor to breast ratio, so if they have a large tumor that takes up a lot of their breast and might require a mastectomy, but they really desire a lumpectomy, we can consider neoadjuvant chemotherapy to try to shrink it down and allow for a lumpectomy during surgery. And then node positive disease that's likely to become negative. And what they're really alluding to is those tend to be the HER2 positive and the triple negative patients that tend to really have robust responses and sometimes even a complete response before surgery. So the benefits we touched a little bit about, but we can downstage patients prior to surgery. We can treat micrometastatic disease sooner. So these patients who have really advanced disease, who probably have a tumor cell or 2 that escaped, will get treated sooner, and therefore we can kill it, increasing their chance for cure. And then lastly, we create opportunity for further systemic therapy postoperatively. And what I mean by that is that if you're giving treatment A preoperatively, then you have a period postoperatively where you could give them a different treatment if you need to give it to them. For example, if they don't have a complete response or if they're a high-risk patient, you've opened up that opportunity, which would normally not be there, to offer them a second option for treatment. The cons are that you could overtreat some patients. Some patients may not need as much treatment as you gave them. And then there's always a risk of disease progression in these situations as well. So we need to be able to either feel the tumor and examine them closely to make sure that there's no progression, or at least be able to image them reliably to make sure that there's no progression as well. So the big new trial, and probably one of the biggest ones we'll talk about today, is in triple negative disease. And so this is a group of patients that have a really high risk for relapse and the cancer coming back down the road. And so they took high-risk triple negative patients, so those with lymph node involvement or more extensively large tumors, and they enrolled them into this Keynote 522 trial, which added immunotherapy to the regimen, which normally was just chemotherapy. Just a note on kind of immunotherapy and the rationale behind it. Cancer normally has mechanisms to evade the immune system, and there's an interaction between the cancer cell and the immune system that the cancer cell is able to turn off. Well, the immunotherapy blocks that interaction and allows the immune cell to recognize that the cancer cell is something abnormal and kill it. And so it allows your immune system to say, hey, this is not normal, we need to kill it. So it works in a slightly different and slightly more elegant way than chemotherapy does. And it's the basis of a lot of new treatment for a lot of different kinds of cancers. So in this trial, they had 3 sort of separate portions of treatment. So part 1 was 2 chemotherapies plus immunotherapy. for 4 cycles. Then they followed it with another different 2 chemotherapies plus immunotherapy. And then they followed it up with surgery and then 1 full year of immunotherapy or pembrolizumab at that time. Before this, the typical standard was to use paclitaxel, which is here, and then these 2 chemotherapies. So we've added not only immunotherapy, but then that brought more use of carboplatin up front as well. So this is a nice schematic that the New England Journal of Medicine put together because this was a pretty big finding. And this is the intervention arm. This is the control arm. And it shows that the patients who received Keytruda plus chemotherapy had a 65% pathologic complete response at surgery compared to about 50% with just chemotherapy. Similarly, they had an increase in their event-free survival at 91% compared to 85% in the control arm. Anytime you add a drug to a regimen, there's always going to be more adverse effects in that arm than there is in the placebo arm. So there was slight increase in adverse effects at 77% compared to 72%. But I think the responses we're seeing really warrant that risk, and most people tend to tolerate immunotherapy relatively well. So that was really the big finding in neoadjuvant therapy, and we're using this regimen a lot and seeing great results. So sort of skipping over surgery, we're going to talk a little bit about the adjuvant chemotherapy space. So what happens after surgery? What do we do, and how do we make our decisions? The goals of this are somewhat similar to neoadjuvant treatment. We really want to identify who the high-risk patients are with an elevated risk of recurrent disease, and then we want to provide them systemic therapy to reduce that risk of recurrence, but also increase survival. Adjuvant chemotherapy in people who have received neoadjuvant chemotherapy has become an interesting space, particularly in the triple-negative space. So if you remember that trial we just talked about, we were giving people a year of immunotherapy afterward. Well, before that, we were giving them another chemotherapy drug if they had residual disease at the time of surgery. We were using Xeloda for 6 to 8 cycles. So now the big question is, well, what do we do? Do we give them the Xeloda as we used to do, or do we give them the immunotherapy like we used to? And there's no big studies answering this question, but we do know that both of these drugs in combination are safe in the metastatic setting. So a lot of new providers are proceeding with both of these drugs at the same time, particularly because patients with triple-negative breast cancer and those who have residual disease at the time of surgery tend to have a very high risk for the cancer coming back. And so the more treatment we can give them tends to be better for outcomes, and as long as they can tolerate it. So the next thing to talk about is HER2 positive disease, which we haven't talked about yet. So this is a realm where we really utilize a lot of targeted therapy, something like trastuzumab or Herceptin, which is an antibody against HER2. So the standard of care typically used to be chemotherapy plus trastuzumab, and then we'd follow that up with 1 year of trastuzumab as well. This new trial, the Catherine trial, were patients that received that regimen, but then had residual disease after surgery. And they introduced them to this new drug called TDM1 and used that instead. So what TDM1 is it's an antibody that's conjugated to a chemotherapy drug. So it delivers the chemotherapy essentially right to HER2 positive cells, as opposed to just generally giving chemotherapy and hoping for cytotoxic effect. Big trial, 1,500 patients who had good outcomes with the new drug. So 88% disease-free survival at 3 years in the TDM1 arm versus 77% in the trastuzumab control arm. And we saw some similar good results in the distant recurrence rate, 10.5% in the intervention arm versus 15% in the trastuzumab group. There is more toxicity with trastuzumab or with TDM1 than there is with trastuzumab because there's chemotherapy involved. It's still generally better tolerated than just chemotherapy alone, but there is a little bit of a trade-off. So if your patient is really frail or borderline, it might not be the right choice, but it really has become the standard of care, and you can see that over here. So the Y and the P delineate someone who got neoadjuvant chemotherapy and then surgery. So if there's any residual disease, the recommendation is to go with TDM1 postoperatively and to switch out that trastuzumab. So this has also changed our practice in the last few years as well. So talking a little bit more about targeted therapy and specifically in the triple-negative breast cancer space. So this is, again, a space where we typically are reliant on just chemo because there's nothing we can target. But about 5% of breast cancer cases are associated with BRCA1 and BRCA2 mutations. Particularly BRCA1 mutations are more likely to be triple negative. And the BRCA gene is involved in DNA homologous recombination repair. And so the rationale behind using other agents, such as PARP inhibitors, and this is that if you block the cell's ability to repair DNA from another mechanism, now you've got two ways the cell can't repair its DNA, and then it would die off. So the Olympia trial sought to look at about 1,800 patients with BRCA gene mutated HER2-negative breast cancer. So they did also include estrogen receptor positive cases, and they gave them 1 year of adjuvant olaparib versus placebo. So these are patients who finished everything else that they were going to get, and then they were put on 1 year of adjuvant olaparib, which is a PARP inhibitor. And the numbers aren't so important, but this chart shows invasive disease-free survival, distant disease-free survival, and overall survival. And you can see that there is good separation of the curves in all three of these spaces. And so olaparib is now recommended to consider in high-risk triple-negative breast cancer, so those with node-positive disease or just poor features on pathology that we see. Okay, leaving the HER2 and triple negative space, we're going to talk a little bit more about the most common type of breast cancer, which is those patients with estrogen receptor or progesterone receptor positive breast cancer. Typically, postoperatively, the way I think about it is these patients fall into one of three categories. One, where they have very low risk disease, small tumors who really very clearly don't need any adjuvant chemotherapy. That answer is pretty clear. Then there's those with really high risk disease, so large tumors, large axillary disease, who very clearly do need adjuvant chemotherapy. And then there's these all others, so this intermediate risk, although I don't know if that's the greatest term, but these intermediate risk patients who have maybe larger tumors, small number of positive lymph nodes, we really didn't know what to do with them, and a lot of them were getting chemotherapy. Then research sort of turned to these gene expression assays. So just a couple of them are the Oncotype, which is what we tend to use here, and then MammaPrint, which take the tumor and give us a number, and according to that number, we can sort of risk stratify them with their benefit of chemotherapy. So we can use that number to say, will they get benefit from it or won't they get benefit from it? The Taylor X trial was one of the first and kind of big trials to help answer this question. So they took patients with hormone receptor positive breast cancer who had had surgery, who would likely be getting chemotherapy, and they ran Oncotype tests on all of them and stratified them into three groups. So those with a low Oncotype score just got endocrine therapy alone. Those with a high score, so greater than 25, got chemo plus endocrine therapy. And then those in this middle group who had a score between 11 and 25 were given either endocrine therapy or chemo plus endocrine therapy. And what they found was the people in this group, specifically the postmenopausal women, did not have any benefit to the addition of chemo. And so that was a huge finding because we could stop giving chemo to a lot of patients that were previously getting it. And it's just really shown nicely in these graphs where you can see the two lines are just essentially the same. There was no difference. There was some slight benefit, and I didn't show the graph here, of patients in that group, so the 11 to 25 group who got chemotherapy if they were younger than 50 or premenopausal. So we'll talk about that in a little bit. But this really highlighted that postmenopausal women in this situation really do not need to be getting chemotherapy because they're not deriving any benefit and only deriving the toxicity from it. The RxPonder trial really looked at a similar group of patients, except that these patients had 1 to 3 positive lymph nodes. And found essentially the same thing. Those patients who had a score less than 25 and were postmenopausal, you can see this chart over here, really didn't have any difference in terms of their disease-free survival with the addition of chemotherapy. And so we don't put these patients through chemotherapy anymore. I mentioned in the last slide, and this sort of shows it a little bit, is that there was some slight benefit to the addition of chemotherapy in premenopausal patients. But again, postmenopausal patients really did not benefit. So in terms of standard of care for postmenopausal women, this is the group I was talking about, which sort of fall in the middle. If their score is less than 26, they can just move on to endocrine therapy. If their score is greater than 26, then they will get adjuvant chemotherapy. Those with really small tumors don't need anything besides endocrine therapy, and those with really large amounts of lymph nodes in their underarm need chemotherapy, and that's kind of where our algorithm has fallen right now. It's a little bit less clear in premenopausal women, and that's because of kind of those findings that I showed you, that there was this intermediary group who had scores in the teen range and did seem to have some slight benefit to Oncotype DX testing. There's a pretty large school of thought here that that's mostly related to the fact that a lot of these women, when they went through chemotherapy, ended up being postmenopausal. And so NCCN and the guidelines we follow sort of give us the choice. They said, well, you could just give them ovarian suppression, or you could give them chemotherapy followed by endocrine therapy. But there's really no clear answer to show that one is better than the other in this population. Again, though, we do know that if their score is greater than 26, they do need chemotherapy. So this is really just that intermediary range that we're still talking about. Okay, so moving on to sort of the last part of the localized treatment of breast cancer, adjuvant endocrine therapy. And those are really the patients that are talking about tamoxifen or anastrozole. And there's really not been a huge ton of new data there, but there's a couple interesting studies, which I think will probably have some implications in the coming years that we're going to talk about. And the first one is those hormone receptor positive patients who have high risk disease. So those who have lots of nodes or a larger tumor, and they were enrolled in the monarchy trial, about 5,600 patients, so those are a lot of people. And they were either given standard endocrine therapy or standard endocrine therapy plus 2 years of abemaciclib, which is a CDK4/6 inhibitor, so a targeted therapy pill that people could get. And you can see over here that there was some slight separation of the curves, both in invasive disease-free survival and distant relapse-free survival over here. That suggests that there probably is some benefit to adding extra therapy upfront to these patients who have high-risk criteria, either by pathology, meaning high Ki-67, or more nodes involved. I didn't show the updated 4-year data, but that continues to show that there is some benefit in these same realms as well. This isn't something that there's a ton of opportunity to do. Most of these patients get caught early, but it is something to consider, particularly in, I think, really young, healthy, robust patients who present in this situation. Abemaciclib is not a terrible drug to tolerate, but it's not the easiest either. It does come with side effects and low counts and diarrhea, and so it's probably best reserved for patients that are really of robust health to talk about this. The next big kind of question that we still haven't answered is the duration of adjuvant endocrine therapy. For the longest time, it's been 5 years, and that's really the standard. There's trials that come up, and this one is such, that try to look at other ways to see if we need to extend that. And so this breast cancer index is a gene expression profile, much like the Oncotype and the MammaPrint, that review estrogen signaling profiles in breast cancer. And this trial basically took a look at extending therapy to 7 versus 10 years. And they found that, you can see over here, those with a low BCI score didn't really have a difference between 7 and 10 years. Those with a high BCI score did. The p-values were not great or very significant, so this really hasn't been, adopted as a complete standard of care, but it is something to consider, especially if you're thinking about it or patients are asking about it. It's a complex topic. At least 5 years are recommended, and that's what I tell the patients right now. I say we'll see where the data's at in 5 years, because it's a long way away, particularly in breast cancer, which has new studies that I feel like come out every week. Those people that are often at highest risk for late relapse are larger tumors, higher grade lymph node positivity. Women with these risk factors and really good tolerance of adjuvant endocrine therapy can be considered for extended treatment. It's probably best just a discussion with them. BCI can help make this decision. It's not something that's in the guidelines just yet, but something to look out for in the future. So that kind of concludes the localized breast cancer treatment portion of this. The remainder is really talking about palliative systemic therapy. So what we do with patients who have metastatic breast cancer. The good news is that overall trend in survival is improving. We saw that chart, which showed the death rate, very slowly declining. Hormone receptor positive and HER2 positive disease still carries a prognosis of years with treatment, which is good for metastatic cancers. Triple negative breast cancer still has a somewhat limited prognosis, and we're talking about a year, 13 months. Anytime we treat these patients, the goal is palliative. We're not going to cure them, but what we can do is try to prevent progression, to prevent symptoms, but also give them longer time. And then overall, what you're going to see in the next few slides and in the next few years, I think, are just that there's a shift to using less chemotherapy and more alternative options. And this is just because, going from chemo to chemo to chemo is really exhausting and it's hard on bodies. And a lot of patients have a hard time tolerating that. And so the less chemotherapy we use and the more targeted therapies or immunotherapies we use, the longer they can tolerate treatment with a reasonable and good quality of life. So that's generally where the trends are going. So the first one we're going to talk, first category is the HER2 positive patients. So on the left here, I sort of just gave a kind of brief primer of where we were at for treatment of this. And the first line treatment was chemotherapy plus trastuzumab or pertuzumab, and that's still the standard of care right now. Second line treatment up until recently was TDM1. So if you think back to that drug that we talked about, which was the HER2 antibody drug conjugate, that's the medication that we're talking about here. And then there weren't any clear, obvious third-line candidates. It was sort of physician's choice. You could do what you wanted, maybe switch to different chemo and trastuzumab, but there was no clear defined line here. The words on this are not so important as just this shows different approvals in the HER2 space. And you can see up until 2015, there were some, but it's just really exploded in the last few years. And the orange boxes are in the metastatic setting. So you can see a lot of new changes in this situation. One of the big ones was updates in HER2 positive disease, in particularly the second line patients. So these are patients who had progressed on chemotherapy plus trastuzumab or Herceptin, who were typically given TDM1. This trial had a new drug called trastuzumab deruxtecan, or Enhertu is the brand name, and they used that instead, essentially. And the overall survival endpoint was not reached, but 12-month survival was about 94% in the trastuzumab deruxtecan arm compared to 85% in those receiving TDM1. And you can see the progression-free survival is quite separated. The 12-month progression-free survival over here was 75% in the trastuzumab deruxtecan arm versus 34% in the TDM1 arm. So those are huge numbers. The trastuzumab deruxtecan did not reach its progression-free survival advantage, while TDM1 did at 7 months about. So this has all but essentially replaced TDM1 as a second-line treatment option for HER2 breast cancer. And HER2 is an interesting drug. It's probably something we're going to hear a lot more of and may even become something that we use in the localized breast cancer space. It's also something that we're using in like esophageal, gastric, and other HER2 positive cancers as well. The next trial is called the HER2 CLIMB trial. The breast cancer space loves to give all their trials these great names. This is a third-line treatment. So these are patients who progressed on chemo plus trastuzumab and then progressed on something like TDM1 or Enhertu. And then they wanted to add a small molecule inhibitor called tucatinib to their regimen. So they did trastuzumab plus chemo plus tucatinib versus just trastuzumab plus chemo. And they saw an advantage here. There was about a 25-month overall survival for the tucatinib arm versus 19 months for the control arm. And you can see here the progression-free survival did have an advantage with the addition of tucatinib, which is a small molecule inhibitor. So what's interesting about this drug is it's one of the few that has CNS penetration. So a lot of the medications we use, chemo, immunotherapy, targeted therapy, don't have great CNS coverage. So a lot of these patients, particularly those with HER2 positive breast cancer, present with late brain metastases because it's a harbor site. The chemo and the drugs that we give can't get there. So this was an interesting trial because they actually allowed the enrollment of patients with brain metastases untreated, and that is pretty unusual for cancer trials. And then because they did that, they were able to give us a whole separate article that talked about CNS progression-free survival and overall survival with these patients. And you can see it was quite good, with tucatinib, trastuzumab, and capecitabine, their progression-free survival was 10 months versus 4.2 months. And similarly, their overall survival was 18 months versus 12 months. And so this is really interesting because I think this is one of the first times that medications can be considered and used to treat brain metastases. Before, we're generally reliant on radiation or surgery, and tucatinib really is one of those drugs that is interesting and that we could use in someone who has maybe asymptomatic brain mets and watch closely. This one's an interesting one. So HER2 low positive disease is somewhat of a new entity in terms of targeting that. So HER2 positive disease is generally defined as people with IHC of 3+ or FISH positive. These trials defined HER2 low as 1+ on immunohistochemistry or 2+ with negative FISH. These are patients that were previously defined according to their other receptors, so they would be considered HER2 negative, so they'd either fall in the triple negative status or the ER/PR+ status. But Destiny Breast 4 sought to try Enhertu or trastuzumab deruxtecan, which is that drug we talked about a little bit ago, in these patients. And so they took about 500 patients with metastatic breast cancer, most of whom had estrogen receptor positive disease, some of whom had triple negative disease, and gave them this drug. These patients had been pretty heavily pretreated, most of them at least getting 2 lines of treatment, maybe even 3. So these are patients that typically will have a pretty poor prognosis and are sort of reaching the end of great or viable options. And I think we got pretty good results in terms of progression-free survival. You can see with Enhertu, it was 10 months compared to physician's choice, which was just generally chemotherapy, was about 5 months. And the overall survival was 23 over here versus 16.8. So, this isn't something that I have tried just yet, but it is something that is promising and can be considered, particularly in patients who have had a lot of pre-treatment and maybe don't have other great options in the, hormone receptor positive state or in the triple negative space as well. And then moving on to triple negative disease. So there's nothing to target with triple negative disease. So typically our treatment was chemo. Just some sort of chemo. And then the Keynote 355 took a look at about 800 patients, and they basically just did chemo plus pembrolizumab versus chemo alone. And they did see that there was a subset of patients who had what's called a combined positive score greater than 10. They saw a benefit in them. And this combined positive score basically is an assessment of something called PD-L1, which is one of the targets of immunotherapy. And you can see over here, the CPS greater than 10, they were the ones that benefited from the addition of pembrolizumab to chemo. So this is standard of care. I mean, anytime there's a newly metastatic triple negative breast cancer, we'll check this because it offers, the option to use something other than chemotherapy in these patients and provide them a benefit with that. Another trial which was interesting and trying to, again, move away from using chemotherapy and trying to use targeted therapy as much as we can was the Ascent trial. And this was a second-line treatment trial which took about 500 patients or 468 patients and gave them this drug, which is sacituzumab govitecan, which is an antibody drug conjugate again, but this targets TROP2 versus just physician's choice chemotherapy. And we saw benefit. So over here is progression-free survival without brain mets. This is progression-free survival in the full population. And with the intervention arm, you can see about 5 months of progression-free survival versus 1.7 months in just the chemotherapy arm. And then similarly, in overall survival in patients without brain metastases was 12 months versus 6.7 months with just chemotherapy. So this is a good new drug that has generally less toxicity than chemotherapy. These are just fun plots to look at. This is a waterfall plot, so you can see all these patients are those who had a decrease in tumor size versus these. So definitely more responses with the intervention arm compared to the chemotherapy only arm. Okay, last sort of group of people to talk about are the hormone receptor positive patients. These are the patients that we see the most, and they're the ones who are treated with endocrine therapy plus a targeted CDK4 or 6 inhibitor. Second line is another targeted therapy plus endocrine therapy. This trial isn't quite ready to, I think, use yet, but it's an interesting trial. It's called the Emerald trial, and it enrolled 500 patients. And gave them this drug, the elacestrant, which was an estrogen degrader. And so they found that there were some people, I mean, overall, all patients saw benefit, but particularly those with this ESR1 mutation. And the ESR1 mutations result in estrogen-independent ER activation. So those are patients who tend to be a little bit resistant to these lines of treatments that we're giving them. And so this is an interesting option that could be something that we utilize in the future, although not quite something that I've seen used just yet. But yeah, that's kind of the big stuff that I wanted to get through. I mean, this is a slide that goes through everything we talked about, which is that neoadjuvant treatment now includes pembrolizumab for triple-negative breast cancer, followed by 1 year of therapy, and that's really a big change that we've seen. Adjuvant therapy in HER2-positive breast cancer can now include TDM1 if they did not have a complete response at the time of surgery. PARP inhibitors, such as olaparib, can be used particularly in BRCA-associated breast cancer, both adjuvant and metastatic setting. We didn't really talk about it in the metastatic setting, but you can. Gene expression assays, such as the Oncotype DX and MammaPrint, can be used to aid in the decision-making for chemotherapy and hopefully prevent people that didn't need chemotherapy from getting it. In high-risk hormone receptor-positive breast cancer, targeted therapy can be used in addition to standard endocrine therapy. Adjuvant endocrine therapy is typically 5 years, but there is a trend towards longer, and you can consider it in some patients or maybe even utilize the BCI to help. And then we talked about lots of new agents, trastuzumab deruxtecan, sacituzumab govitecan, in the metastatic setting. So we went through a lot of information here. There's a ton of future directions for breast cancer, and it's hard to kind of narrow it down, but ultimately we want to optimize our treatment decision-making for chemotherapy in the localized breast cancer patient, who needs it and who doesn't, because we don't want to be giving treatment to those who don't need it. Particularly premenopausal women are the ones we sort of still have a little bit of question marks around. We want to identify more potential targets for therapy, ideally in triple-negative breast cancer, maybe looking at immunotherapy some more. Really what's, I think, very important is to investigate the role for imaging and screening. So we use mammograms right now. The TMIS trial is looking at roles for 3D mammography as standard of care. And then the Wisdom study is taking a look at targeting screening just based on the individual woman. So looking at their risk factors, deciding what they need to be screened adequately with and doing it that way. And then the last one's an interesting one, circulating tumor DNA. So there's a couple trials that take a look at this in breast cancer. We certainly can run it. We get information from it. We just don't know what to do with that information right now, whether it means we do more systemic therapy or less. Just clarifying the role of that, I think, will be really, really important for these patients. Thank you for your attention. I'll take any questions. If there's questions in the chat here.
There are no questions in the chat.
Okay. All right. Someone will tell me then. All right. Well, thank you.
Thank you.
Yeah.